Thank you very much for kind introduction and kind invite to this wonderful initiative. This is really my pleasure to be here and to talk about my forte and where I always would like to educate or explain how important it is to treat GDM properly, how to manage it. So my topic given is recent guidelines in management of GDM. So thank you, Cheryl and whole DAYDEIC team for this initiative and opportunity. Uh, as we all know, that gestational diabetes is purely diabetes when it comes between 24 to 28 weeks. But this is called uh, real gestational diabetes or pure gestational diabetes. But nowadays, we are seeing more and more early cases of gestational diabetes. The cases of gestational diabetes which comes before 20 weeks of pregnancy or 20 weeks of gestation. So 85% of the cases, the pure gestational diabetes are glucose intolerance with first onset during pregnancy. And 15% of cases which are actually called DIP, that is diabetes in pregnancy, which are actually type 1 or type 2 or even pre-diabetes, which we already knew that they are diabetic and they are getting pregnant. So unattending pregnancy or diabetes first time detected during pregnancy, these are called DIP. And if first time hyperglycemia is introduced and HbA1c is less than 6.5, then we are going to call it gestational diabetes. So I'm going to talk about mainly gestational diabetes, but I had to explain you what is gestational diabetes and what is diabetes in pregnancy. So this is one of the concept that you need to know. So GDM represents detection of chronic beta cell dysfunction. So I would say gestational diabetes, it is a beta cell stress during pregnancy or beta cell test during pregnancy and in which pancreas fails. So gestational diabetes is stage in the evolution of type 2 diabetes. So the lady who is getting gestational diabetes has very higher chance of getting type 2 diabetes if they don't take care of themselves, in especially in lifestyle modification and weight gain. So implications, first you need to understand that women with history of GDM are at increased risk of future diabetes. It is not only about their diabetes, predominantly type 2 diabetes, but also in their children. The chances of those children whose mother has type 2 gestational diabetes has higher chances of getting obese and then further type 2 diabetes. And if they are female child, if it is a female child, then chances of getting gestational diabetes in second generation is also very high. So it is transgenerational transmission that occurs and which is really an important issue in gestational diabetic mothers. So women with gestational diabetes, this is also one of the important points. So as we are discussing recent things, so women with gestational diabetes at higher risk of premature cardiovascular disease. This is also very important that women with history of GDM have higher prevalence of metabolic syndrome, increased risk of cardiovascular disease. So over 10 years, women with GDM, so the women who had GDM, after 10 years, they have more non-invasive cardiovascular diagnostic procedures, simple cardiovascular events, and total cardiovascular hospitalization after adjusting for age, ethnicity, and comorbidities such as preeclampsia and obesity. This was one of the important study which was published in 2022. So now I'm going to explain you about guidelines of screening. So first thing we need to understand that screening is universal in India, and we have to screen each and every mother for who is getting pregnant or who has chance of getting pregnant or who are trying for pregnancy. So from first trimester, we should ideally screen them Why universal screening? Because India is at higher risk of getting gestational diabetes, especially our Southeast Asia region. So single test procedure of DIPSI is approved by Government of India. It is endorsed by Ministry of Health. Government of India is an affordable test to meet the requirement of all strata of society. This test procedure has been approved by WHO, FIGO, and International Diabetes Federation. So first screening, ideally, though our all obstetricians are not following this guideline, but they should be screened at first trimester between 12 to 16 weeks. Then second screening should be between 24 to 28 weeks. And if it is again negative, then third screening should be between 32 to 34 weeks. And how we should screen, that also I'll be explaining. That is single test procedure. So diagnostic criteria for estimating hyperglycemia in pregnancy. So if you want to learn more about screening methods, here you can see those all methods are relating to fasting plasma glucose 1 hour, 2 hour, and 3 hour as well. So there are Carpenter, Carlton, USA criteria, which you can see here that it has screening method of three tests: fasting, 1 hour, 2 hour, and 3 hours. WHO also has mainly two tests: fasting and 2 hours. IAD, PSG, ADA, and FIGO, they have a fasting plasma glucose, 1 hour and 2 hour of screening. But DIPSI here, you can see it has only one single test procedure where at even non-fasting state, we can check their blood sugar after 75 gram of glucose, anhydrous glucose. And if it goes beyond 140 mg per dl, then it is called gestational diabetes, and it has similar kind of screening efficacy in comparison to IAD, PSG, FIGO, or ADA. So a NICE guideline also has the similar kind of screening method like IAD, PSG, and ADA. So our for our Indian population, which are very high risk of getting gestational diabetes, so we have just single test procedure, and which is approved by our government. So again, I'm going to explain you. Hyperglycemia in pregnancy is an umbrella term. Under this, it comes diabetes in pregnancy, which I told you that if the patient is already known case of type 1 or type 2 diabetes, then it is called diabetes in pregnancy. Whether they come to know during pregnancy that they have type 1 diabetes or type 2 diabetes, as if they have HbA1c more than 7%, 6.5%, then they automatically come under diabetes in pregnancy under HIP. But if their HbA1c is less than 6.5 and purely gestational diabetes case of 75 after 75 gram of blood glucose, if fasting plasma glucose is more than 100, or postprandial plasma glucose after 75 gram of glucose, it is more beyond 140 mg per dl, then we label it as gestational diabetes. But mainly we do this test after 24 weeks. But according to guidelines now, we should test in each trimester as early gestational diabetes cases are increasing. But in DIPSI, there is no rule of fasting plasma glucose, but you may check fasting plasma glucose if you want to make sure that it is case of gestational diabetes according to ADA and IAD PSG criteria. So pre-GDM and GDM. So pre-GDM is diabetes in pregnancy and GDM is gestational diabetes purely. So hyperglycemia at conception is associated with the risk of congenital malformation. So here you can see that at 7% of HbA1c, the risk of congenital anomalies per 1,000 singleton pregnancy is around 38 or 40. So 40 pregnancies are at risk of getting congenital anomalies out of 1,000. But if you see HbA1c, as HbA1c increases at 10 or 10.5% of HbA1c. You can see here 120 pregnancies are complicated with congenital anomalies. So it increases by around 3 to 4 folds. So every 1% increase in HbA1c, the odds of pregnancy being affected by congenital anomaly increase by 30%, which is quite high. So we should try to keep HbA1c less than 6.5. And this is also one of the important a message and which is included in all the guidelines. So now I'm moving to management of hyperglycemia in pregnancy. What should be the target? Target according to DIPSI, it should be fasting should be less than 90. So it should be between 70 to 90, and PPBS should be less than 120. So you can keep it between 95 to, so postprandial blood sugar, you can keep it between 100 to 120 or even 90 to 120, and mean plasma glucose should be between around 100. So you can keep it mean plasma glucose between 95 to 105, and HbA1c should be less than 6.5. So targets during pregnancy, here you can see 1 hour and 2 hour, but we strictly follow 2 hours. Yes, you may ask patient to do 1 hour postprandial blood glucose, and it should be between 110 to 140. So 1 hour can be 20 mg per dl more than 2 hour postprandial, but I follow 2 hour postprandial. And continuous glucose monitoring target. Here we need time in range more than 70%, and the time target range is between 63 to 140. I'm going to explain you in next few slides. We have a specific guideline for continuous glucose monitoring in GDM. Now it is approved in GDM. It's been more than 3.5 years that continuous glucose monitoring is approved, and the target range is between 63 to 140. It is not like type 1 or type 2 diabetes where we keep it between 70 to 180. Here, whether it is type 1 diabetic patient who is getting pregnant or type 2 diabetes and gestational diabetes, where we want target range between 63 to 140. Here in type 1 diabetes lady who is getting pregnant, we want their time in range more than 70% with less than 25% where hyperglycemia is there. Hyperglycemia here we define as more than 140 mg per dl, and less than 5% we want hypoglycemia. And pregnancy with gestational diabetes or type 2 diabetes, where we want a target range of 63 to 140, more than 90% in a day. So here it is completely different. Only one kind of patient where we want time in range more than 90%, and that is gestational diabetes and type 2 diabetic lady who is getting pregnant. So 63 to 140 and 90% time in range, where we want both 5% more than should be less than 140 mg per dl, and 5% should be less than 63 mg per dl. So hypoglycemia also should be less than 5%. So management of diabetes in pregnancy, definitely the approved treatment is insulin and also metformin after 20 weeks in according to our Ministry of Health guidelines, DIPSI guidelines. Even ADA guidelines, they also suggest that you may use metformin after 20 weeks. In case of PCOD, you definitely can use metformin up to 30 to 14 weeks until organogenesis, and you stop from 14 weeks to 20 weeks, and again you can start metformin. So insulin, which insulin to be used? So FDA in pregnancy labeling guideline, they have approved almost all the insulin, regular insulin. Here I'm going to explain you that even DAYDEIC insulin, the long-acting insulin, which I'm going to explain, basal insulins, where DAYDEIC, Detemir, NPH, and Glargine, almost all the insulins are approved. They don't have the label indication or the category that used to be before 2015, that category B and C. Now it is up to doctor or treating physician, how they want to treat with basal insulin. But the basal insulin in true GDM or pure gestational diabetes cases, it is required in only 20 to 30% of the cases where fasting plasma glucose is not controlled even after metformin and postprandial blood glucose comes down. So in such cases, around 30% cases, we need basal insulin. In early gestational diabetes cases where gestational diabetes comes before 20 weeks or even 15 weeks, in such cases, definitely we need to use basal insulin. So there was one study in type 1 diabetes where it showed that type 1 diabetes in expect trial, it showed that degludec insulin is completely safe. And on the basis of this study only, it was approved in Europe and now it is approved in India since 1.5 years. So basal insulin in pregnancy, here you can see according to our Indian CDSCO guidelines, Levemir, Lentus, Tresiba or Toujeo. So Glargine, Detemir or Degludec, all insulins have almost similar kind of label indication. So it's up to doctor or physician or diabetologist who is treating. It's up to them whether they want to use whichever basal insulin. So we have also one of the paper of basal insulin, that is Glargine U300 safety in pregnancy, and soon we are going to publish it. It was abstract uh, submitted in IDF 2022, and now we are coming up with full paper of Glargine U300 safety during pregnancy. So which insulin to be used? Except insulin glulysin, almost all the insulins are approved and safe in pregnancy, though glulysin also has data for pregnancy, but very small number of patients data is available till date. So you can use whatever insulin you are comfortable with, but premix insulin should be avoided. And now the regular insulin are also, they are sluggish. So you may use rapid acting insulin and ultra rapid acting insulins, including basal insulins like degludec and Glargine U300. Now the metformin, which is approved in European guidelines, this study was done in 2023, and it showed that it has this extended release of metformin has been approved as first oral anti-diabetic medication to be used safely during pregnancy and throughout all the trimesters. So you can use it in first trimester, second trimester, or third trimester. If the doctor is comfortable, they may use, especially in obese patient, PCOD patient, in the metabolic syndrome patient, and the patients who are not getting control even after basal insulin, and they don't want to start that multiple daily injections, you may start metformin in such cases as well. So metformin in pregnancy, according to AD and ACOG guideline, as I already explained, you may start in PCOD up to 14 weeks, you stop it, and again you start after 20 weeks. After organogenesis, you should stop. Also, Indian guideline has the similar kind of data, and the Indian guideline also suggests the same thing. So diabetes in pregnancy impacts two lives. Diabetes in pregnancy identifies women at risk of metabolic problems, and maternal hyperglycemia is associated with development of metabolic problems in offspring. So future of female gender getting gestational diabetes is also very high. Hyperglycemia during pregnancy is associated with high risk of maternal and perinatal morbidity and mortality. So it should be ideally managed properly with HbA1c of less than 6.5, fasting less than 90, and post-meal blood sugar less than 120. So it's an opportunity for primary prevention of NCDs and cardiometabolic disorder. With this, I'll conclude the talk. And thank you very much for thank you very much for patient listening and kind invitation. Thank you again.